Moving on to the next speaker, Dr. ARUN, who is the Deputy Director of Center for Digital Health at Public Health Foundation of India. And he's going to talk about how digital health can act as an enabler for small hospitals.
A very good evening to all of you. And again, my sincere apologies for joining online because of some the circumstances of today. I'll be making a very quick presentation regarding digital technology solutions and how digital health can act as an enabler for small hospitals. The earlier speakers were absolutely brilliant, fantastic presentations, and I'm very glad to have been enlightened by their presentations. I'll be talking a little bit about how providers can connect to their patients and elaborating that through a case study of sorts of some of the work that we've been doing at Public Health Foundation of India using digital health. So before we move on to the actual topic, digital health in itself is a very, very, very widely used term, but it encompasses a lot of different aspects, including genomics, precision medicine, interoperability, telehealth, AI, machine learning, gamification, and so much more, including the wearables and Internet of Things. I often ask this question: can we improve healthcare access using digital health? And I think it's a very important question for all the hospitals today to make their services accessible to their patients. And almost all the time, the answer to this question has always been yes, we can improve healthcare access using digital health. But if we pose the exact same question in a slightly different way, does digital health always improve access in healthcare? The answer may not be yes. And this has been shown to us with several examples. And the most recent example in healthcare is when our COVID application, which has been lauded for its work, initially faced a lot of criticism for being exclusive and for excluding the digitally deprived population from its portal, because all the people who had to book for their vaccination had to go on the COVID portal, and this discriminated against the digitally deprived or the digitally illiterate population in India. And the Supreme Court had to flag it and take necessary steps to take care of this particular inequity that crept into digital health. So the question is, how do we build that connect between the care providers and the users? So I'm going to be presenting a case study on telemedicine, on how we can build equity and improve access. And in this context of today's conference, how to make hospitals smarter using telemedicine. So, as we all know, in 2020, shortly after the onset of the COVID pandemic in India, the MCI released the telemedicine practice guidelines. And there were various policy reforms, not just in India, but across the world, that liberalized the use of telemedicine so as to make healthcare accessible during the pandemic. However, even today, there is a digital divide. There's poor penetration and acceptance of telemedicine in rural areas, and also subpar utilization in the urban areas. We all know that teleconsultations increased many-fold in the country, in India, after the COVID pandemic, but has that rise been uniform across rural as well as urban areas? And we all know that hospitals across the country instituted their own telemedicine programs, but how successful have those telemedicine programs been in bridging the gap between their patients and the hospital? So I think most would agree that the telemedicine systems that were set up by hospitals in India and across the state in Kerala itself mostly cater to follow-up care for the patients that had already visited their hospital, because of the limitations that telemedicine has today. So when we did a market research, we found that there were barriers at different levels. At the patient level, there were challenges in accessing telemedicine services, either due to literacy, because most of the telemedicine services were tailored for an English speaking and an English reading population. The language was a problem, and many of them had technological barriers, especially the elderly were not able to access telemedicine because of these barriers. When we spoke to the physicians, they themselves did not enjoy being on a telemedicine platform because they lacked a good clinical history or physical examination findings or laboratory parameters that usually help these physicians in making a good evidence-based decision. And when we scope the digital technology field, we found that there were multiple excellent innovations out there, but the issue was that none of them were interoperable. And all of these innovations were either being used in isolation or not being used at all because physicians had to usually download multiple applications on their phones or on their PCs to access these technologies. So we instituted a telemedicine initiative in India called as Digi Sahayam, which loosely translates to digital health, which is basically an assisted telemedicine solution. And this program is a blend of how health system redesign or healthcare redesign can be paired with technology so as to make it more accessible. So what we focused over here was on the upscaling of the skills of the healthcare workers in providing assisted telemedicine, in which a nurse or a allied health professional would be providing that telemedicine service to the patient and connecting that patient to the doctor. We try to improve access to primary as well as tertiary level care through these personnel. We try to improve the quality and the scope of care that can be provided through telemedicine using point of care diagnostics, electronic clinical decision support systems, and various other health technologies. We try to reduce the need to come to health facilities for their follow-up visits. And these health facilities were largely inaccessible during the wave of the COVID pandemic. And we also integrated real-time monitoring and feedback mechanisms that can help assure quality. So what were our solutions for those specific barriers? The first, patient-level barriers were taken care of by the trained healthcare worker that would connect, convey the findings, and facilitate that doctor-patient interaction, and also prevent wasteful visits, which we encountered as a very common problem on all telemedicine platforms, where patients had to generally choose which specialist that they wanted to meet. And very often, they did not understand the nuances between, for example, a nephrologist and a urologist. And very often, these would end up being wasteful visits for the patient. The second challenge or the barrier, which was the physician level barriers, again, the trained healthcare worker would act as a bridge that collects history, performs a physical examination, carries out lab investigations before initiating a teleconsultation, and thereby saving the time and also improving the quality of care that can be provided by a physician. Regarding the telemedicine platforms and the various digital technologies, what we did was we created a very innovative, interoperable telemedicine platform, which embeds multiple digital health technologies, including electronic health record system, point of care diagnostics, inbuilt. Am I audible?
Yes.
Okay, sorry. So inbuilt electronic clinical decision systems, as well as numerous state-of-the-art digital health technologies. So we call our telemedicine platform the PHFI Innovations for Tech. And I'll be talking a little bit about the digital health technologies that we've integrated into the platform. So the first one is the Empower, which is an electronic clinical decision support system that was developed by the Public Health Foundation of India, along with the All India Institute of Medical Sciences and the Center for Chronic Disease Control. And what this basically does, it uses a machine learning AI-based algorithm so to provide physicians with guideline-based decisions for their hypertension or diabetes patients. And in its backend, it has around 2,500 to 3,000 case studies that create the best possible evidence-based decision for their particular patient. So for example, it would tell whether to increase the dose of a drug, add a new drug, or it would also caution the doctor about possible interactions between their drugs. We also paired it with a point of care device that was developed within PHFI called as the Swasthya Sahayak, which comprises of around 15 investigations, including 5 vitals. So the blood pressure, oxygen saturation, the pulse rate, temperature, everything would be captured in a single device, captured and transmitted via Bluetooth to the telemedicine platform. It is also capable of doing multiple point of care investigations like blood sugar, urine protein and sugar, hemoglobin, hepatitis, syphilis, dengue, malaria, HIV. All of these tests would be done on this particular device, which is the size of a tab, and it would be transmitted via Bluetooth to the telemedicine platform. We also paired it with Indian-made ECG device, which is FDA approved and CE certified and capable of capturing 6 to 12 lead ECGs. And what this would do, this would transmit the ECG captured by the nurse or the allied health professional and transmit it via the cloud to the physician on the telemedicine platform. And it would also have an AI-based interpretation that would help physicians understand what the pathology is. We also thought that the platform should have eyes and ears of the physician. So we paired it with a digital stethoscope called as the EcoStet. And through this, the physician sitting at the hospital would be able to hear the heart and the respiratory sounds of the patient. We also paired it with a camera that is completely controlled by the physician. The physician, through the telemedicine platform, could actually zoom and rotate this camera 360 degrees to have better control over the visual inspection. And not just these technologies, we are constantly looking out for more technologies to be paired and integrated with the system so as to stand by our aim of being interoperable. So this is a view of what the telemedicine platform looks like. So when the physician opens the patient record, the physician has access to a very elaborate history. So unlike usual telemedicine platforms, which the patient needs to explain the history, we've created a template-based, symptom-based history-taking format, which allows a minimally skilled healthcare worker to collect history as efficiently and as thoroughly as a normal physician who's undergone medical training. And so what happens through this is that the doctor, before they start their telemedicine consultation, they have access to all the history that they would like to have before starting the consultation. So it also captures history regarding the presenting illness. So it's not just the patient presents with fever, but the moment the nurse clicks on fever, it asks a bunch of leading questions like how is it intermittent or continuous? Is it severe or mild? Is there diurnal variation of the fever? They have to collect history regarding their personal history, their past history, their family history, any drug history. So the doctor gets a complete picture of what the patient is going through. The vitals are captured through the Swasthya Sahayak device, and it's available to the physician with the trends or the longitudinal trends, which allows the physician to actually see how the blood pressure has varied over time. Or, for example, in the COVID time, it actually helped the doctor monitor how the oxygen saturation varied over time. The lab results that come from the Swasthya Sahayak get embedded into the telemedicine platform. And again, this is available in a trends view through which the doctor can see how, for example, the blood sugar or the hemoglobin has changed over time. There are ECG readings that is available with an AI-based interpretation. The Empower or the electronic clinical disease support system is there within that same dashboard, and it provides them suggestions on how to treat their patient for diabetes or for hypertension. There's a place where they can actually enter their e-prescription, and they can look at the prescription summary of other doctors, and they can mark the follow-up visit for the patient with which the platform would send automatic reminders through SMS to the patients to come back, and you can also mark the patient for referral. In addition to this, the stethoscope is also visible. You can see the small icon for the stethoscope, and using that stethoscope symbol, they can actually hear the respiratory and cardiac sounds that have been captured through the digital step. So we thought of multiple models of service delivery, and some of these models may be a good way for many of the hospitals today to expand and reach out to the periphery. So we started off with a model of designated telemedicine centers. So these are very small clinics that are run by a nurse and a lab technician. And all you need to run these clinics is around 350 to 400 square feet of space. And all the telemedicine equipment fits well within there. And we made available general physician specialists as well as super specialist consultations available through these clinics. And existing private facilities as well have been upgraded to perform these assisted telemedicine solutions. So what happens in these clinics? The patient visits the clinic, a trained nurse takes the history, conducts the examination, conducts any lab investigations, and then they connect the patient to the doctor over the telemedicine platform. And immediately a specialist consult is arranged for them, and post-consult counseling is given by the trained nurse. And what we try to do is minimize the time that the patient spends at the clinic or at the hospital. So in a hospital, consultation with 2 or 3 doctors may take anywhere between 2 hours to an entire day. But in these clinics, we try to do it within 30 minutes. And within 30 minutes, the patient is examined, history is taken, and they finish a consultation with an MBBS physician first and a virtual consultation with specialists as well as super specialists. So what we found was that this model could also be used to deliver doorstep or on-foot telemedicine assistance, because all of the equipment that we have are battery powered. They work with a very simple 4G internet connection, and they all fit into a very compact backpack. So you can see our nurse who actually went from house to house and connected bedridden elderly patients to the physician directly from their homes. And imagine getting all these telemedicine along with these digital health technologies from the home itself. We conducted various camps using a mobile kiosk setup in public spaces, in trains and metro stations, in bus stations, in malls, and we've conducted a lot of these kiosk setups also. There's also a concept of doing this on wheels, where the clinic could be going to remote and far-flung villages to provide these services. We've also looked at ways to integrate this into government health facilities, and we're currently working with state governments to integrate this telemedicine facility into their health and wellness centers as well as the primary health centers, because they already have the necessary staff and resources. All they need is the assisted telemedicine platform and the digital health technologies. The potential impact that we see from this is that this model can bridge the gaps between the community, technology, and digital healthcare. Using these trained personnel, we can improve continuity of care and longitudinal health data through the use of these inbuilt electronic health records, create an innovative model for health service delivery that can ensure sustainability, accessibility, and affordability of care. We've considerably reduced the indirect healthcare costs related to travel and loss of daily wages. We can provide valuable data that can inform the development of suitable healthcare models and also prevent complications through improved awareness, detection, treatment, and timely referral. We've addressed a lot of the issues that health technology faces today, including cost, quality control, interoperability, the scalability, and we've tuned the telemedicine system to user experience and the contextual needs. This is also a very climate-friendly way of providing healthcare. And this was recognized in the recently held COP26 conference of the UN Climate Change. And we were presented as one of the case studies in the Pockets of the Future handbook that was distributed at the COP26 conference in Glasgow. These are our various partners. We started off with the first project using a CSR grant from Star Health and Allied Insurance, followed by funding from the World Health Organization, the Southeast Asian Regional Office, that supported us for setting up a regional demonstration site. And we're working with the Haryana state government to expand this model to the government system also. And we work very closely with all the local NGOs, local institutions so as to provide the care. Our first project is called the Star Arogya Digiteva, through which we established 3 clinics, one in the rural village of Pasuvantanai of Toothukudi district and 2 in the urban slum locations of Chennai city. And through this particular project, we've done more than 16,000 consultations over a span of 16 months. We've seen that this model is particularly accepted amongst the usually marginalized communities like the elderly patients above the age of 60 years. 30% of our patients are elderly. More than 60% of our patients are females. We've seen over 6,000 cases with various non-communicable diseases. We've detected more than 1,500 people with diabetes and newly detected more than 2,000 patients with hypertension. And through our community outreach program, we've touched more than 30,000 lives. And using a cost analysis, we've seen that with every visit that a patient makes to a clinic, they save approximately 917 rupees coming to this clinic. And when we did a satisfaction survey, we found that there was very high levels of satisfaction amongst the patients with this model of delivery. As I mentioned earlier, we're working with WHO and the state government of Haryana to set up a regional demonstration project that will be evaluated and scaled up to the entire Southeast Asian region. And I also wanted to say that this also provides hospitals. So they say that all hospitals that engage in research is going to be a cut above the rest. And what on the surface is virtual care, this platform also provides the hospitals and healthcare providers with ample opportunities for research because it provides an infrastructure to create, evaluate, and scale up various digital technologies, use the information for digital disease surveillance and epidemic or pandemic surveillance. You can use these clinics for capacity building, for community outreach. Using the community outreach arm, you can conduct various surveys and population level studies. Using the well-trained staff, you can collect complex data for your research initiatives and also use the electronic health records for various solutions, including AI and ML-based solutions. So with this, I'll stop my presentation. Thank you once again to the organizers for giving me an opportunity to talk on this platform. And again, my apologies for not being there in person. Thank you so much.